About replacement at the moment at least, but never say never. AI won't replace doctors, but doctors who use AI are more likely to replace doctors who don't. And this is not a dramatic oversimplification, and we're going to talk later about why. So what is artificial intelligence? Artificial intelligence is the capability of a machine to imitate intelligent human behavior, such as learning, reasoning, problem solving, perception, and language understanding. And the question after is, isn't our intelligence enough? Think of having two very professional and skilled, trained attendings that are given the same task. And you give them a task and you give them different tools. It's like giving one a screwdriver and the other one a drill. Who do you think is going to finish first the task? Who do you think is going to have more time at the end of the day? Who do you think is going to have more energy at the end of the day? So of course we're smart, but we can use also smarter tools. And of course, change always feels unnatural, and it feels unnatural until it becomes essential. And there are so many big advances in our life right now that we cannot think our life without them. And think of GPS, for instance. Does the fact that we have GPS make us less of navigators? No, the difference is that we can travel more, we can do it more safely, and we can do it more efficiently. And that's the day after, that's how we're going to be thinking. So actually, there was a survey last year, we did it, and we found that most of the interventional cardiologists are actually very positive about integrating AI in the cath lab and in their lives in general. They believe that it's going to increase diagnostic efficiency, diagnostic accuracy, and treatment selection. And at the same time, they do have some concerns. They do believe that we need more training because we may not understand AI to just use it on patients. And when it comes to the one taking the final decision, they do believe that the physicians will be the one taking the final decision. However, in terms of accountability, they're an increasing percentage thinking that they're not sure who should be accountable because we're using something that it was approved by FDA probably. So who should be accountable? Us, the companies, organizations. So their main concerns that we have to discuss before actually integrating everything in our workplaces. We published this early last year, and what we did is that we tried to see how well does ChatGPT do in the interventional cardiology certification exam. And it actually passed the exam, however, it underperformed compared to the fellows. However, we did the same at the internal medicine exam, which is a more broad medicine domain, and we found that it did actually very well. It did a lot better than internal medicine residents. So we should make sure that we check this because the models are changing. We use different models. We use different domains. So we have to make sure that we understand what are the defaults of these machine learning models. It can help us with diagnosis, it can help us with procedural planning, it can help us with interprocedural guidance, and it can help us with prognosis. During this presentation, we're not going to focus on FDA-approved devices that use AI and machine learning for interventional cardiology, but let me speak about prognosis a little bit more. We published this last year, and it's a prediction model for predicting a successful crossing with primary undergrade for CTO-PCI, and it actually gave us a great AUC, but the question is, why are these models using AI usually better? And the answer is that they detect non-obvious patterns and complex relationships that humans or linear models cannot detect as easily. They're not static models. These models are learning models. Then they can use unstructured data and do more individual predictions. So how is it different? Linear regression is what we usually use in statistics to make a model. And this is like a junior fellow who is very good with guidelines and basics, and it makes a lot of assumptions that are usually linear. So increasing age gives us more risk, for instance. However, XGBoost, for instance. XGBoost is the machine learning model that is very useful in healthcare, and it's actually one of the most powerful ones. And it's like an experience attending. So it can pick up several patterns from experience. It can correct mistakes and know when the rules bend. So it's not just about the guidelines. It's when these guidelines have to bend. And let's go to HR. So electronic health record is one of the main projects that increase physician burnout, and we all know that, and we have experience with that. And it's a project that was overpromised and under-delivered. What we see, a recent publication from this year, seen that AI digital tools can actually comprehensively voice patient needs and can be very much help for the physicians. And of course, this impacts well-being. So there are first studies showing that all these AI models are actually helping the decrease of burnout. What about augmentation? This article was published earlier this year in New England Catalyst, and it actually is the experience about 1 year experience with AI scribes and over more than 2.5 million uses. And as you can see, there's a growing use of AI scribes. And I'm curious, have you ever tried? Is anyone who tried AI scribes? And actually, cardiology was one of the first 5 domains that in which AI scribes were used. And you see, we have decreased use time for notes. What about administrative tasks? I think that when we all sign up for med school, nobody liked administration, right? So if we can use AI to just eliminate these tasks, that would be great. And I'm actually doing it a lot, and I know a lot of my new colleagues are doing this. So make sure you just think broad when you're using AI and make administration the least of your concerns. And research now, I'm a researcher, and I think most of the researchers use AI at the moment. And actually this study, showed that 40% of the researchers, about 2,000 participants in this survey, are using AI at the moment for parts of the research process. And you can use it for anything, but they're mainly using it for administrative tasks, writing and editing manuscripts, and of course, reviewing of the literature. Emotional support now. I mean, I'm not saying that ChatGPT can be a therapist, of course. However, there are increasing studies in major journals showing that people are actually increasingly using AI for emotional support. And for physicians, this should be particularly interesting. And a discussion like this can never finish without speaking about the risks of a reliance. We cannot just say that, okay, ChatGPT said it, and that's correct, right? Garbage in, garbage out, what does this mean? This means that if we're giving bad quality data to these LLMs, we're going to get bad quality outputs. Bias in these algorithms, if we're training these algorithms only just thinking of white males, they're going to give us a result about white males. Black box AI, this is about transparency. If you don't understand how something works, of course, you cannot just use it on patients. You should be able to explain to the patients how you came up with this prediction or how you came up with this guidance. And of course, ethical and legal uncertainty. So the question, and actually a senior colleague asked me once, he was like, is this going to make us intellectually lazy? And there's a very recent study from MIT answering this question, to try to answer this question actually. It got a lot of popularity. They had 2 groups comparing a group that was using LLM, a user that was using a search engine, and a user that was using only their brain for taking essays for like 4 months. And they actually found that the group that was only using LLMs consistently underperformed in neural, linguistic, and behavioral levels. So, of course, our brain, we have to train it. It's just to be on performance. Of course, everything should be in moderation. And I tried to emphasize this just by putting HIPAA there like a billion times, but you cannot give any patient information on any ChatGPT or any other LLM that is not HIPAA compliant, and most of them are not. So you should make sure that if you're giving patient information, your LLM is HIPAA compliant, or just be sure to de-identify this patient information. And accountability now. A computer can never be held accountable, so it cannot make a final decision, of course. And what about the productivity paradox? So we cannot expect miracles happening overnight. And usually what it happens when we speak about productivity is that we have this valley of death, meaning that before getting to a spike of increasing productivity, we're going to get down first. Because we have to get familiar with all these major technological advancements, and not just get familiar with them, change the workflow. So what we do to get up to this spike, because probably now we're there in the valley of death, is that we can change the workflow in order to assist all these different with AI. And what's the day after? We just got accepted an article at the European Heart Journal on retrieval augmented generation. And what this is about training these models, giving them information that we trust, so we get outputs that we trust more than the usual outputs. And what we did is that we gave them the guidelines. Cardiology is a very evidence-based specialty, and we saw that it did a lot better. So that's how it's going to go. Key takeaways. AI is not here to replace us, it's here to support us. We have to embrace change thoughtfully. We have to collaborate and question, ask how these tools are made and from whom. And of course, stay clinically in charge. Thank you.
Hello, okay. That was great, thank you so much. Why don't you stay on in case there's questions from the audience. So before we start, by way of hands, who's using AI scribes? So it seems about a fourth of the audience. And I guess the next question I have, as you were giving this presentation, before you gave it, I'm thinking we're going to talk all about AI scribes, but there's so many platforms for AI. So, from the panel, Katherine, can you tell us what is your most innovative way you used AI?
Oh, I don't use AI nearly as much as I should. I think I use AI a lot for summarizing literature searches is what my current use is. I think it's a good, if I have just a question that I don't know the answer, I used to start on UpToDate, and now I start on ChatGPT, and I ask them to give me references, and that's kind of where I start. That's my current use. I really look forward to a day where we can start using it in diagnostics, because I think so much of our initial diagnostics are subjective, right? I don't know that AI is going to be able to, in the short term at least, tell me fix this vessel versus not. But it should say, hey, look harder at this vessel. This tapered LAD lesion that you were calling 50%, maybe put a wire down that. And that's kind of like a future that I'm pretty excited about.
Yeah. That's funny that you say that, and I don't know, Manos, if I'm giving away this surprise for the next talk, but we're going to be talking about, not this talk, but we're going to be talking about CT guided, and I think they're using a lot of AI diagnostics to predict ahead of time what lesions, how severe lesions are, to guide you on your PCI. But
I was curious, your thought about machine learning versus artificial intelligence and the effect about garbage in, garbage out affecting the outcome of AI.
That's a great question, actually, and I think that that's how we try to answer that with retrieval augmented generation, and that's actually the second paper we're writing right now, and that's the one I was speaking about, the European Heart Journal, is that because of getting so much garbage in, we get so much garbage out. So what we want to do is to make sure that when you're using an LLM, when they find an article from New England, they're going to treat it usually equally as a random website, right? So that's what we say when we say garbage in and garbage out. So we should make sure that what they use when they're giving us outputs are information, knowledge that we trust. And that's the start and the example with the guidelines, is that we should make sure all the information given, it's not garbage. So the guidelines is just the start. And we saw that, we did this study, and it's going to publish later this year. And we saw that when we're giving them guidelines, and we're saying, so you should first check the guidelines, and then check whatever. Because, of course, it's not that you're just checking the guidelines, they're checking the information you give, and then whatever. So when you're first checking what we suppose as is the gold standard, they're giving a lot more accurate outputs. So I think that's where we're heading, to cardiology-specific LLMs.
Just a question about the generative AI in the office. So we know one of the causes of burnout, or one of the frequent complaints, is too much time on the computer typing, et cetera. Is there been enough data yet that showing us that clinicians feel better if they're using AI-assistive techniques in the office and in doing patient records?
I wouldn't say enough data because of exactly of the productivity paradox. So at the beginning, you have to get familiar with all these changes. And at the beginning, every change is going to feel like it's more work because you just get used to doing that for so many years. But at the beginning, you may expect actually more exhaustion. So we expect that. It doesn't have to surprise us, but it has to be fast. And how it's going to be fast? So it has to be in a learning healthcare system. That's how it's called. So you have to actually go get AI scribes, and at the same time, make sure you change the design of the workflow in order to just get out of this valley very early.
Yeah, I think that we introduced it at Cleveland Clinic, and I believe that they had a survey, I guess it was through Ambient, and they were able to show that it was definitely a reduction in work time, and physicians overall felt that they were less stressed at the end of the week. I think there's a lot of opportunity, and we're using now AI to further things like minutes from our administrative meetings, like our coronary heart team meetings and all of our meetings. We're using AI for that too, the same way.
So Tim, you're about to do a procedure. AI has said you must put a 3-5-18 stent to fix that lesion. Are physicians going to believe it?
Yeah, there's going to definitely be a learning curve or a trust factor that's going to have to grow, in all of these areas, whether you're doing research or looking for clinical evidence, because as you said, garbage in, garbage out. Yeah, I think that's the tricky thing, is that it's a bit of a black box. You know, you don't know what's going into it, and so when it spits out an answer, you just kind of have to blindly trust it until you get some experience with it. I'll just add to your point. We've started using AI scribes at our facility, and I think it's been pretty universally loved in the sense that, you know, it definitely eases my workload. I'm not that great of a typer to begin with, and I don't have to type so much. And the other advantage I see is that it just allows me to have a lot more face-to-face time with the patient, eye-to-eye contact with the patient, because I'm not, you know, constantly trying to keep from getting behind on all that stuff I have to do on the computer.
All right, well, thank you very much. To keep us on time, we're going to move on to our next speaker, Poonam Velagapudi, who's going to talk to us about the causes of burnout. And if I got your name wrong, Poonam, I'm sorry.
Did a pretty good job.
I'm getting closer. Right here.
I'm going to talk a little bit about the causes of burnout, and we have other speakers who are going to tackle how to deal with those problems. Well, as an interventional cardiologist, I guess most of us here are. When you wake up in the morning, how many of you wake up with these thoughts, or really, you know, have these thoughts through the day? You kind of plan your day and expect that it be all smooth and everything is so organized, but then it ends up being like this. And we tend to, however, get through the day without really, you know, thinking about ourselves, and then kind of get ready for the next day, and it goes on and on and on. So this is the outline of my talk. I'm going to talk a little bit about what burnout is, what's the scope of the problem here in the United States mostly, what are the tools to assess burnout, and what are the drivers or causes of burnout. I do not have any disclosures relevant to this talk. So burnout is caused by some sort of a stressor. It doesn't have to be just work. It could be in your personal life or anything, a stressor that happens over and over again, and then you lose interest in something because of that. So there's depersonalization. There's three important things: emotional exhaustion and reduced personal accomplishments. So it's sort of, you know, it's a, I would say, a continuum from stress to burnout. There's a very important difference between stress and burnout. Stress is more of an adrenaline state where you're very overreactive. You want to, you know, respond very quickly to something. Whereas burnout is more sort of I call it a flat effect, where your emotions are blunted and there's helplessness, hopelessness, and, you know, lack of motivation. And then there's all this damage is mostly emotional, whereas stress is mostly a physical sort of damage. So we all know about the burnout curve, and why it's important to recognize burnout is that there's been a lot of information that suggests that if it's identified early on in the curve, before you actually lead to that, you know, flat part of the curve where there's collapse, it's easier to, you know, go through interventions and get out of that situation. So there's several tools. I'm not going to go through them in detail, but there's a Maslach burnout inventory. It's a 22 questions survey, an American Psychiatric Association survey, as well as a mini-Z survey by AMA. And ACC has developed a mini-Z, a mini survey as well, which you can access it through their websites. So I'm just going to throw out a few questions here, and just, you know, you can answer by raising your hands, or just, how many of you have missed a celebration because you're at work or you're on call? You know, you couldn't take a sick day off because you have a full schedule, though, you know, you really want to stay home. How many of you have had an occupational health problem or have had a colleague who's had one? How many of you couldn't make to the doctor's appointment on time because you're stuck with patients? How many of you wished you could spend more time with a loved one, you know? How many of you wish you didn't need to chart at home after work? How many of you seeing too many patients in clinic, or like you're not happy with the administrative support you have? So I think I see a lot of hands raised to those questions, and so rest my case, right? But the prevalence of burnout is not inconspicuous. So this is a report from Journal of Interventional Cardiology, Invasive Cardiology, by Alexandrou and Manos and group. They've actually put together all these trials, surveys that looked at interventional cardiologists, fellows, including program directors, and looked at the prevalence of burnout was 25 to 70%. It's quite high. I mean, I was surprised when I was actually going through these articles. 70%, that's quite a lot. That's more than half of us. Factors contributing to burnout. That's the same manuscript. Again, I went through all these reasons, and if you look at each one specifically, mostly the first one, the ACC survey that was done in 2018, most of the causes are related to work. Hectic work, no control over workload, misalignment of values, so on and so forth. So pretty much related to work and lack of the life outside of work. This is another survey that was also done by Manos and group that was published in 2023 in JACC Interventions, where they surveyed interventional cardiologists across the world. And there was 50% peeps were from North America. And these are the components of burnout. They asked them to rate from a scale of 1 to 10. And you can see more than, most of the people were burnout, 7.2, working too hard, 7.5, stressed, 7, emotionally exhausted, 6.4, frustrated by work, 6.1, oh my God. And these are the factors contributing to burnout according to that survey: insufficient income, too much paperwork, lack of administrative support, yada, yada. Same thing, all that stuff that we just talked about and looked at the previous manuscript. Same thing with an ACC survey in 2018. People who were burnt out, about a quarter people said they were extremely burnt out. And out of those quarter people, you can see the reasons listed downwards here: job dissatisfaction, misaligned values. So all these are kind of similar from what we just saw with interventional cardiologists. So what are these causes of burnout? Let's look at each one individually. So long duration of training. Your counterparts are 21, 22 with a job, but then you're going into residency and all these, financial responsibilities, the debts, and then the pay is not so much, you're working too hard. And you're 33 or 35 by the time you're done with interventional cardiology fellowships and, you're in an actual job. And so that can lead to really significant burnout. Supply-demand mismatch. This is a huge thing. There was a survey in 2009 that said there would be 4,000 cardiologists deficient by 2030. And this increases workload for everyone. The years of work increases, people retiring later, doing more STEMI call, seeing more patients, etc. And this is another survey that shows, that the net annual workforce, we are at a deficiency of 500 for cardiology. And then academic dissatisfaction. Obviously, you're doing more work, you don't have time for research, there's less research funding. And the other side is true too. Some people are doing too much teaching or too much travel and too much time away from family. That's not good either. So that's another big cause of burnout. Administrative, EMRs, and lack of support from the administration. So how many meetings do we attend when you wake up in the morning? We all went into, medicine to do clinical work, but just think about your day. How many hours of of the day you're spending in meetings? And then your other responsibilities, email fatigue, your EMR inbox messages, etc. And then lack of personal time and all these occupational related injuries. We just did a survey into 2023 where 66% people reported pain because of wearing lead. So all these things are really important. They kind of add up, and the consequences are not inconspicuous. You can see people really, not just us, the physician, but there's people around us who are impacted. Patient care, families, healthcare, as well as your own personal health. So I think it's a big and very important topic that needs to be addressed, and looking forward to the solutions by the next speakers. So thank you.
That was great, really great. on the panel, who has had experienced burnout or is burned out? Okay, I'll ask Allison. Allison, can you tell us, what do you think, obviously it's a sum total of all the causes that Poonam had mentioned, but what do you think, if someone was to say to you, how can I help you, what can I do, what would you want to take away from your day-to-day life that would help burnout?
Absolutely. So I think one of the things that I recognize as a big contributor for me is when a large portion of my time is given away to what I would call busy work in a sense and redundant things, and documentation and dictation, going through stacks of patient files that are literally paper results in my case. I remember a certain point early when I started my current position where it got to the point where I was spending every single weekend catching up on dictations and things like that, and I realized I was miserable because I wasn't pursuing any of my hobbies or interests that I actually enjoy. But it was all of that. It wasn't the day-to-day clinical work per se. It was all of that other paperwork and administrative type stuff that I had to do. So that's something I've really had to work on, actually, and I'm definitely in a better place with it now, but I remember specifically being miserable with that at one point.
I think that, how many of you guys feel that if you can take away the charts to the patients and the dental clearances and stuff, that would maybe take away a large portion of your burnout? Anybody?
How many people like their Epic inbox?
So can you tell us, Bill? You just raised your hand about burnout.
I'm giving a talk on this. Burnout is from a variety. The biggest reason we feel burned out is nobody loves us. Let's be honest. We compete against each other. We compete against our partners. The administration doesn't give a rat's ass about you. So, and you just get, hey, see more people with less time, see more people with less time. And we don't know how to say no because we're hyper-competitive people who say yes to everything until you finally implode. And so I just think that our culture that we train in, the culture that we work in, and the culture that we've been brought up to treat each other is very self-destructive. And I'll get a little bit more of that into my talk, but I think the real key is we have to figure out how to show compassion for each other and how to put boundaries that I don't have to take care of every patient. And I don't have to be there for every case, and I don't have to be there for every meeting, because in the grand scheme of things, I hate to tell you this, if one of you drop dead right now, your patients will get seen tomorrow. You think you really matter, and the reality is you don't. And you're being treated by people who don't think you matter.
Wow. Poonam, oh, sorry, did you want to say something?
So this is for a well-being session, right? Just to summarize.
I had a question. Is there any data to say if private cardiologists are happier or academic?
So one of those surveys that I showed had more academic cardiologists, close to 40% compared to private.
They're basically equivalent. The difference is academics is usually about ego and academic resources, and private practice is about people fighting over money.
One of the things that I've learned in my early career is learning to recognize when I'm starting to dance on the edge of burnout, because I wasn't always good at seeing it in myself. So I'll tell you what the red flag that I watch for carefully in myself is when I just get completely indifferent to patients thanking me. You know, I ran into a patient in the elevator the other day who's a hospital employee, thanking me for saving their life in front of the whole elevator. And I was like, okay, thanks. Or like the patients are thanking you profusely in the recovery room, and you're just like, okay, how long does this need to go on? And so that's my red flag, and I think for me, my biggest trigger to burnout is lack of agency. When the pieces of my life outside of the hospital are forced to get smaller and smaller and smaller to make room for the hospital getting bigger and bigger and bigger. And so I think boundaries are important, but they're hard, especially in the early parts of your career, to actually stand up and hold to. And so I think I started my career with this great idea of I'm going to have boundaries because they're important, and that just is not realistic. But I think recognizing okay, I need to have some boundaries right now because I'm dancing on this edge of burnout has been an important skill that I've been working on developing.
Yeah, you make, oh, sorry, there's a question, go ahead.
Hi, thanks for the talk. I think it's very important work. I think Dr. Lombardi might have alluded to this, but given that interventional cardiology is, a high-powered, competitive, overachieving field, there's more awareness about burnout in the newer generations of clinicians. People in the panel are leaders in the field. Do you think that the field itself is going to be accepting of this change and conducive to it, or is going to shift more towards thinking that, it's going to be seen more of a weakness? And if yes, how can we secure against that? How we can protect against that, I guess?
Dan, are people going to be accepting of the newer generation having bigger boundaries than us?
I'd like to say yes, Bill, to that I think there is a very slow evolution. I think, as you pointed out, it's a tough nut to crack. Most of us came up in the system where you just came in earlier, worked harder, stayed later. But I do think the newer generations of physician training are changing that a little bit. Usually when we hire people, one of the very early parts of the conversation is about work-life balance. And so I don't know, I'm a glass half full guy, so I'd like to think that the administration is beginning to hear that and think about it. I don't think it'll change overnight. I think you've inspired all of us. We've heard your stories, and I think that's opened some awareness. And I think the concept of boundaries is extremely important, and you have to choose something that's important to you, whether it's setting a workout schedule or going for a walk or just being out of the hospital or having a date night or whatever those things are, and that will help. But at the end of the day, I do think there's some evolution in acceptance of this by the work of panels like this.
All right, I'm going to keep us moving on, but I would also say is don't worry about it. You just take care of yourself. So with that, let's talk about how to increase physician well-being. I'm going to slaughter your name, so I'm going to let you introduce yourself. I know we've met before,
It's
but
Nkechi Ijioma.
Nkechi? Are you doing that? I'm going to destroy that. I'm sorry.
But you did a great job with everybody else.
All right. Well, thank you, everyone.
50% of the time, I get it right every time.
Thanks, everyone, for the opportunity to present today. So my name is Nkechi Ijioma. I'm an interventional cardiologist at The Ohio State University, and I'm here to talk about healthcare system innovation as we try to increase physician well-being. So I have no disclosures. So we're going to outline the importance of institutional strategies in promoting well-being in interventional cardiology. And then we want to also review institutional strategies that will help promote well-being in interventional cardiology. So show of hands here in the audience, how many people here are leaders at their institution? In one way or the other, you're a leader in the cath lab or you're a program director. Okay, so some people. Okay. And so why is it important for us to talk about institutional strategies? We've heard from the first speaker about the role of AI in helping to improve efficiency and hopefully make our lives a bit better as we work in the clinic space. But we also heard from Poonam about the different things that lead to burnout. The institution is also important because, as Poonam showed us earlier, there are so many drivers for burnout. And most of them, if you look at the slide out there, most of them are based on what we are doing at our institution or our workplace. So the workload and job demands, efficiency and resources, control, which most of us don't have control. It's more of a leadership issue. Finding meaning in our workplace. We have some control, but sometimes we don't, because sometimes our institution tells us what they want of us, and that may be different from what we came into that job thinking we will be doing. And then also alignment with the organizational values and in community at work. So as you can see from these different drivers of burnout, that most of these are driven by things that we have no control or have little control because they're being driven by our leadership or the rules or regulations at our workplace or what is expected of us at our workplace. We do have some information about interventional cardiology. So as Poonam also mentioned earlier, Dr. Burlakis' group up in Minnesota has been very proactive about looking at interventional cardiology in specific to find out what is it that's driving burnout in interventional cardiology. So we applaud you, Dr. Burlakis, for what your group is doing, because we have lots of information about general cardiology, but positive data of what's happening in interventional cardiology. But so people out there who are interested in research, please get into this space in interventional cardiology. And as you can see out there on the slide, that lack of admin support, support, too much bureaucracy, lack of respect, even in an interventional space, even though we feel like, oh yes, we run in, we're macho, we do everything and we save lives, but there's lots of things that we have no control over that driving burnout in our subspecialty. As Poonam said earlier as well, SKY is also looking into how we can improve well-being in interventional cardiology space. SKY recently conducted a survey, and we found that if you look at occupational health hazards in our subspecialty, radiation, orthopedic injuries are a big problem in our subspecialty. 66% of the respondents reported that they had musculoskeletal pain. 6% had been diagnosed with cancer. So that's a big problem. So not only, the work-life balance that we have to struggle, that everyone else has to struggle with, in our subspecialty, we have to worry about radiation safety, which none of us have control over other than, you do your ALARA, you put on your lead and the distance and all that, but how is the cath lab set up in terms of what are the protocols for that radiation safety? Most of that's been driven by our leadership. And orthopedic injuries. And I think one of our speakers is going to talk a little bit more about these issues, but these are things that institution plays a major role in helping us to make our lives safer and healthier in interventional cardiology. So how can institutions help to solve this? Well, the American College of Cardiology, in conjunction with the ESC, European Society of Cardiology, looked at different factors, and a couple of things they came out with were organizational culture of well-being, so make sure that there's a just culture, a culture in the institution that supports well-being, improving the efficiency at work, so we heard about the role of AI, and destigmatizing mental health conditions, and as well as strengthening personal resilience. The work done by Dr. Berlaxis and group also looked at other things that people from interventional cardiology suggested as reasons or ways that we can improve our well-being. And once again, it comes down to things that the institution can do. Less paperwork, more respect, better admin support, getting rid of obsolete rules, hospital food, I guess, better call rooms. So once again, the different things that institutional leaders can look at and say, how can we make the lives of interventional cardiologists more meaningful to them and more effective and improve both mental health as well as physical well-being. And you can't manage what you do not measure. So we have to get data. You have to know what's happening in your institution for you to make a change. So just looking at what's happening in the global scene is great, but also know what's happening in your local practice. So do surveys. Find out what your institution, what are the things that are making your interventional cardiologists having that imbalance in their work life? What are the things that stress them out in terms of mental, physical health issues? And then apply intervention specific to your institution, both in preventing burnout at your institution, as well as treating your providers who are undergoing stress in terms of burnout. So in summary, you should know the data in your institution. That's the first for our leaders. And then apply that data to ensure that you have a culture of safety and well-being, changing employment policies, improving the efficiency at the practice, and then addressing occupational and radiation safety, which is very important for us as interventional cardiologists. So thank you. I'm going to open up for discussion.
How many hospital administrators are in here? Excellent.
I like the list of things you mentioned, obsolete rules. There are just some stuff, like for example, we have trouble with our administrative assistants in that they're wonderful, but there's just not enough of them and they have too much to do. So we're trying to recruit more, but they have this policy that you can't work from home. And I think if you can attract people to have 2 days working from home, you'd be able to hire more. So those obsolete rules, those absolute, there's no particular reason for it, they were just created and they're never readdressed. I think it's really an important part of addressing work-life balance. And personally, I feel that, you're constantly being told, oh, we've got these meetings for you if you're stressed out or whatever, but just, why don't you just have somebody answer my epic emails?
I was going to say, how many people get the wellness videos that Glockenflug talks about? Here, are you burned out? Take this 10-hour, 10-week, help you get better. Does that make anybody feel better? Right, so pick one thing you wish Ohio State would do to make your life better.
I think one thing that our new division chair is doing is looking at our how we are being, I wouldn't say paid, how our work is being evaluated in terms of moving away from RVU so people are not competing amongst each other. I think that's a brilliant thing that our leadership is doing right now at Ohio State. And so once again, sometimes that competitive that you alluded to can make people do crazy things, and then we just work over and keep over and over working ourselves and lose work balance. So that's one thing I think my institution is doing, is moving away from RVUs to another way of making sure it's a bit more fair, but also having balance in what we're doing and still achieving the goals of the institution.
Let me know if you're hiring. I'd love to. I was told point blank by my chief last year that, because I thought my role would be is I should be coaching my junior partners, and because I'm pretty good at what I do. And what I was told is that my value is my own personal RVUs. So being here at this meeting costs me RVUs. If I train a fellow and it costs me a case a day, that's my money.
It's true. There's
Felt great at an academic center.
Yeah. So we have a couple of minutes. And I'd love to start the panel and sort of what Nkechi just did. Tell us if you can think of one thing that contributes to burnout and that you can find a foreseeable solution. And we have 6 minutes, so 30 seconds a person.
Yeah, I think this is a little bit controversial, but I actually feel very happy. But what I do, I actually feel privileged that I get to do what I do on a daily basis. Maybe it's my first year as an attending. My workload is not that high yet. You know, I think we impact patient lives. I think I do feel appreciated, at least by my patient, which makes me happy. I think we're well compensated, for sure. We have good job security in general as doctors. And just driving back home, you know, seeing people on the street, I feel really blessed. I mean, they struggle, people really struggle, so I guess I'm a guy, cup half full guy.
Everybody's gonna get their job with you.
But yeah, no, I mean, and I mean it. I mean, I'm happy. Again, could be just workload didn't catch up yet to me. So, yeah.
Great. Thanks for being so positive. I love that.
Yeah,
Allison?
So I guess just looking at simple practical things at my institution, I'm in Canada and Newfoundland, and we don't have a proper electronic medical record. So we are hoping to get Epic in the very near future, and although I know it has a lot of downsides as well, if you compare it to what I'm currently dealing with, I think it'll make a major difference for me. So that's like a real tangible, easy thing that can be done.
Yeah, so I think it's a hard sell to get hospitals to spend money to make physicians happier, right? So for me, if you want to make me, and I think most of us, the theme is going to be an answer of like the hospital needs to spend more money on X. So for me, they need to pay our cath lab staff better. We have a lot of cath labs in Atlanta. We're really, yes, thank you, whoever's clapping. We're really competitive with our good staff, right? We're losing good staff. So I am constantly training new techs. It is one of the banes of my life of, you know, a brand new grad, or we bring up people with no cath lab experience into the lab, teaching them to scrub. And I'm on the very front lines of teaching people to scrub diagnostic cases for the first time as a tech, which is terrifying. But it's just money, right? We just need more money, and that has to come from admin. And so that's a problem.
I hate RVUs. Just give me a yearly salary and let me teach people and take care of patients. I'm very frustrated by the competitive RVU stuff. It's annoying me.
I love your points. I think I feel like you in that there's turnover, whether it's turnover in tech staff. I can imagine every time you have to train somebody. But for me, again, it has to do with the administrative support. And it might not cost money, again, getting back to that, you know, let them have a day off, a day working from home, something that is innovative and creative in keeping with contemporary times and yet not costing them any money. So I really think that if we can find a solution to helping our staff, whether it's cath lab staff or administrative staff, they would make my life easier.
Yeah, I worry about the time that people spend on call overnight and then are expected to work a full day the next day. I worry about that for their own health and safety. And so there's some efforts being made to try to reevaluate that. I think most of us have come through this system where we work all night for STEMI call and then come in the next day. I don't think that's a good plan, and we could change that. That's something we're thinking about.
In thinking about institutional contributions, I'll highlight the important role that physicians can play in leadership. You know, when I look at my institution over the 20 years or so that I've been there, the institution has gotten bigger and bigger and bigger, and there's more of a disconnect between you know, the leaders of the hospital and the, you know, the working class physicians. And so they just don't necessarily understand what we're up against or some of the struggles that we face. So I always appreciate when there's a physician in that role, number one, although that's not really my dream job. I'm glad it's somebody's dream job that they'll do that. But I think just the importance of, you know, establishing and maintaining that relationship, because, you know, even our leadership, as much as we like to blame them for everything, if they don't really understand our problems and our challenges, then they can't be a part of the solution.
I think we're physicians because, okay, sure, number one, we need a job, but we also like to help people. Unfortunately, these days, for example, for me, I do PCIs. People refer me to do PCI, and then sometimes I don't even see the patient in clinic after that to see how, you know, to thank me in person and shake my hand. Why? Because I have a nurse practitioner for that, and I have to see a new patient, and I only have 15 minutes. So something that made me very happy would be if I, instead of like 15 minutes, I had half an hour with each patient, try to meet them a little bit better, and have a chance to even, you know, see them after procedure and thank me in person.
Yeah, and I think the panelists have brought up some very important points here. So one is importance of having physicians, interventional cardiologists get into those leadership positions, because people, sometimes our leaders don't know what we're undergoing and what we're going through. So in terms of radiation, in terms of the lead, the back injuries. So having more physicians who are inspired to get into leadership, interventional cardiology is important. So if you're inspired to, please go ahead and, you know, take leadership position. And another person mentioned culture. So having a culture of, you know, of collegiality, you know, so I think Dr. Bill Lombardi talks a lot about complications and things like that. When people are working together as a team, so making sure that our institution has that culture where people work together, they can help each other out when there are complications or stuff is going down in the next room. I think that also helps people to have well-being at the workplace. And then when complications do happen, mitigating that second victim syndrome.
Well, you're about to get one of our surgeons, so.
That's really great points. All right, so now we are going to have the answer to all of our questions. So on an individual level, what can you do to make changes and do interventions? And none better than Dr. Bill Lombardi to answer this question.
The ultimate imposter syndrome. I'll do my best in 15 minutes. Oh. Let's go the other direction. So our jobs are hard. Anybody think their job is easy? It's hard. It takes a lot out of you. You sacrifice a lot. 14 years of your lives. I grew up before workout rules. My intern year, I worked 5,000 hours. I've had more complications in the cath lab than anybody else on planet Earth because I've done probably more CTOs than most people in the United States. It takes a lot out of you. So some of the things I've learned along the way, life is short. Like I said, if I drop dead tomorrow, how will I reflect on my legacy? One of our colleagues in the CTO space, Timothy Mixon, passed away this year at 53. How do we feel about that? How did he feel about that? What do we do about that? Be careful of seeking perfection because you're not perfect. You just want to get better. Competitive people want to win. There is no winning in this game. You're defined by what you think is success. Is it really success? So this is a curve. It's a self-reflection curve. We're all in different places. But realize this is self-perception. How good you think you are and how good you actually are vastly different. So how many of you have been coached to get better at your job in the last 5 years? Checked your ego, went to somebody's lab, and said, hey, teach me how to do this procedure, or teach me how you do what you do. Probably none of you, okay? Must have got a fellowship recently, or you're a good person. How many of you have had leadership training? We always talk about, well, we should have doctors in charge. Do doctors make good leaders? Actually, usually not. They're arrogant, they don't listen, they make decisions. If you look about how to be a good leader, it's the exact wrong things. And how much training have you had in your fellowship and your faculty and your attending to be a good leader? And you want to talk about your mental well-being? How many people here, if you're burned out, depressed, and unhappy, you need a therapist because you obviously can't coach yourself through it. Let's see if I can get this the right way. There we go. Right? We talked about this earlier for AI. I'm glad that AI has to go through the same thing. It's called the Valley of Death. In our world, as you learn to do things, you fail. How many people in here like to fail? How many people here like to have complications? So the Valley of Death, you have complications, right? And the old guy in the room or the old woman in the room is like, you shouldn't have done that. You shouldn't have done that. That was a bad procedure. Really? If nothing bad had happened, would it have been okay? Are we talking about the outcome or are we talking about the indication? When you're in the Valley of Death, hospital QI, I do consulting for hospitals. Hospital QI harms more people than it helps. Right? Public reporting harms more people than it helps. Because what it leads to is risk aversion. And the people who derive the most benefit are the ones at the most risk. So if you do the lowest risk people, so what you do is acts of omission harm way more people than acts of commission. And while you're not committing anything, you're actually not learning anything because you're not doing anything to learn to get better, because you're avoiding the things that it'll take to get better. So that's a culture problem. Life can be better. Say goodbye to my boat. I'm selling it. That is my coaches, Aaron Grantham and my son, Ryan. So why are we burned out? Are you set up for success? Right? Hey, can you see that extra patient? Let's start that high-risk PCI at 6 o'clock at night with the new tech who scrubbed one case. Right? You don't need a good administrative assistant. You can do it yourself. Pick up the phone. Right? Are our expectations of ourselves realistic? You're a hyper-competitive, successful person, right? Define success in interventional cardiology. Volume, money, ego. It can be local ego, city ego, state ego, country ego, society ego, world ego. I would be world ego. Does that really define you as a successful person? And if you do more PCIs than somebody else, does that make you better at your job? Does that make you happier? Maybe not. When was the last time somebody in your lab had a complication and you went up to them and hugged them and said, I'm sorry, are you okay? When was the last time anybody did that for you in your program? Did anybody stop, take 5 seconds, and just be like, are you okay? That sucked. I'm really sorry for you. Wouldn't that be nice? Why don't we model that behavior? Right? Do you know who the worst, between the physician, that's a terrible emotion, and the other is, it's usually a nurse. The nurse is the one that's most devastated because they're the last person that saw that patient alive. Have you ever gone to the nurse and said, hey, let's talk about this? Not, what did you do in the case? How did you respond? How did you, hey, are you okay? I can't teach you anything if you're like traumatized. Do you feel loved? Do your administrators love you? Do they care about you? Could you pick them out of a lineup? Right? I won the Hartz Award, the Heisman of our profession. I got a form letter from our CMO that said, Dear William, congratulations. And it was the exact same 3-sentence letter that they give for Seattle top doctors. I spent 2 weeks with it in my email box going, I want to send it back and say, this is worse than actually not sending me anything. And how many of you get asked to do more with less every day? We don't have enough cath lab staff. We don't have enough time. Is that going to make you happy? That's my other son. So here's the other thing. Coming from a world-class, angry, judgmental, awful human, blame anybody but yourself. It's the administrator's fault. It's the economics fault. It's my wife's fault. It's my partner's fault. It's whatever person close to you that you can kick, you're going to pass the blame on. So here's the first step. Jim was talking about this. What do you actually control in all of this? You. You control your response. So I have epic anger management issues. The last couple weeks, it's actually been worse. I've lost a little bit of control because of some things going on in my life. When I get angry, I have to ask myself, why am I angry? Is being angry helping me? Can I fix the problem that's making me angry? If I could fix it, can I fix it now? If I can't fix it now, do I want to spend the time later to actually fix it? By the time I get to the end of that, you know what I had to say? I don't care. And I'm a lot happier now because I don't care. I don't control it. It's not my fault. It's not a judgment on me as a person. I'm doing my best. To get to that place took 3 years of therapy, reading about 100 books, and every day showing up differently than I used to. When I started this, I hated myself. I had a lot of self-worth issues. And I used to tell myself probably 20 times a day in the cath lab, I suck. That was actually my common theme at the table. I suck. I'm terrible. I can't do my job. Could you imagine that? That's my self-talk. Right? Anybody else got bad self-talk? Next time you have bad self-talk, think about what would your friend actually tell you. If you're spiritual, what would your spiritual leader say to you? That should be your self-talk, not I suck. So my counselor made me, every time I thought that, I had to say, I'm a good and worthy man. Now, I didn't believe it. I would say it 20, 30 times a day because I had a lot of negative self-talk. It took me a year before I actually, you know what, I am a good and worthy man. I became that person. I manifested it. But it took 20 times a day, every day, for a year. And I still do it right now. I was out playing golf with a good friend this weekend, and I had to step back because I'd hit a bad golf shot, and I've got some stuff going on in my life, and I just stepped away. I stopped, I looked up, and I just appreciated the beauty in which I was in. I got to control my response. I could get angry, I could scream, I could cry, or I could try to find joy and find happiness. Because you can be happier. Catching king salmon in Alaska is fun. What's some of our challenges? We just talked about this. We do not have leadership in medicine. We have management. And the way I define leadership is I will work for you despite. I will follow you because. Managers just tell you what to do and don't give a crap whether you're there or not. Do you know why all your cath lab staff are leaving? Because nobody loves them, right? Why was there so many turnover during COVID? If I'm going to get treated like crap and I can get paid more, who's going to move? You're going to move. I'd rather get treated like crap and be paid more money. And since you're treated the same everywhere, you go where the most money is. You want to keep your staff? Show them love. When something goes wrong, it's your fault. When they do something right, credit them. Encourage them to ask questions. Find out about their lives. Unconditional love makes things better. I care about you. And not saying I care about you, it's I'm worried about you. Are you sleeping? How do you change? Therapy, daily practice, manifesting what you want to be. Think about who you'd like to be in a year, not who you've been right now. Boundaries. When somebody asks you to do something, so when I came back from my leave of absence and I was trying to rebuild myself, they wanted me to do 4 cases a day. And I said, no, I'll do 3. No, you have to do 4. I said, well, then I can't teach the fellows, so I'm not going to do it. So I said, no, cost me some money. You know what? We're in the top 1 to 5% of wage earners in the US. Who cares? Number 2, my backlog started getting longer. So I would tell the patients, call the CEO of the hospital. Here's their email or a phone number. Maybe they'll listen to you. It's not my fault. I'm not the one causing this. If you want me to be more efficient, talk to them. Don't blame me. That's what part of the problem is. Because you're the patient interface, you get all the blame for what somebody else is doing. Just make the people who did it accountable. The other thing I want you to take home from today, how many of you say no to things at work? None of you. Because you're competitive, got to take care of the patient. It's the way you've been trained, right? When you say yes to work, who are you saying no to? Yourself, your wife, your husband, your mother, your father, your kids, your friends. Every yes has a no. Think about the no and what it means. Practice in advance. What do I really value? And when push comes to shove, say no to the extra patients so you can make it to your kid's game. Say no to the administrative meeting because it doesn't really matter. It's going to be the same meeting every week for the next 5 years and nothing's going to get done. Why go? Go run. I haven't gone to an administrative meeting in 4 years, and I don't care. I never will, and I'm not going to go because nothing gets done, and it doesn't make me happy. So I take that hour, and I go for a run. I'm the fittest I've been, and I'm the lightest I've been. Because you don't want to be that guy. That's broken Bill. That's 60 pounds, a really nice beard, and a very broken person who had no self-worth because I was extrinsically validated, right? I got to get the dopamine hit. Oh, Dr. Lombardi, you're amazing. Oh, Dr. Lombardi, thank you so much. Oh, Dr. Lombardi, you're this. Oh, Dr. Lombardi, you're that, right? And you keep, come on, more heroin. Give me that dopamine. Make me feel good about me. Till you realize it's never going to make you feel good about you because there's not enough in the world to fill you up. So then I had to work on, I'm a good and worthy man. Just 'cause. I have intrinsic self-worth. Lots of stuff happens in my life now, but it doesn't mean anything about who I am. My job is to give myself grace and forgiveness and try to show up with compassion and love. So, we talked about radical acceptance. I would talk to you about Ted Lasso via Walt Whitman. Be curious, not judgmental. Most importantly, don't be judgmental of yourself. We're terribly, terribly hard on ourselves. And from that, give grace. Do you know what? Every one of you is going to have something go wrong today or tomorrow or the next day. When it happens, that doesn't mean you're bad. It doesn't mean you're a horrible person. It just means I did my best today, my best wasn't quite good enough. That's okay. Give yourself grace to fail. Remember your values and that you're worthy. And I hope what you see from me is vulnerability is not a weakness, it's a strength. Be vulnerable with your colleagues, be vulnerable with your cath lab staff, be vulnerable with your partners, be vulnerable with your spouses, be vulnerable with yourself, and you will get to a better place. If you want to learn more about this, we do almost a whole day on psychology at the Complications course. It's next July. I run a podcast. It's a shameless plug, but the podcast mostly talks about leadership, mental health, just things we all deal with in a vulnerable way. These talks can be hard for people to get up to the microphone and ask a question, so I will leave my email and cell phone there if you need help. Thank you very much for the time. I'm sorry for going over.
Bill, that was just, I get chills every time I hear you speak on this. I know you spoke at Sky. It's just really amazing to hear somebody in your position and the struggles you go through and every single point you had. I'm sure everybody in the room had experienced a similar point or all of your points. I personally experienced all of your points, except for maybe the 50 pounds more and the beer belly. But other than that, it was like everything was what you had gone through. So thank you so much. Okay, so in the interest of moving on, and Dr. Lombardi said he's available for questions after, we're going to go on to our radiation-led and well-being talk by Dr. Houman Khalili.
All right, that's an easy talk to follow. Thanks for that, Manas, putting me after Dr. Lombardi. All right, so I'll be talking about radiation-led and well-being. So we all have heard about some prominent cases of left-sided brain tumors. Interventional cardiologists raised some eyebrows and concerns by the community. And there is data also that there is detectable evidence of radiation-induced DNA damage in the bloodstream in long cases that involve radiation. In this particular study, in folks who are doing endovascular aortic repair, these signs really peaked a few hours after the procedure and subsided in the ensuing hour. This is a mock-up. This is a study from Mayo, mock-up of the skull of an operator, of a theoretical operator that's doing a case. You see radiation exposure, particularly at the bottom part of the skull, and with reducing intensity as you go higher up. Primarily, this is radiations because of scattered radiation, and that's the primary mechanism of exposure for the cath lab staff is really radiation scatter. Although operators and staff get small amount of radiation compared to the patient, but this is cumulative. It's repeated exposure over years and years, and eventually can cause injury. You guys have probably seen this slide. The radiation exposure is determined by 4 things: intensity, time, distance, and shielding. And these are the things that we try to work on. Patient variables, body size, these are harder for us to control, but there are behavior modifications, behavioral variables like the operator's use of equipment, how they're going to use it properly, and as well as equipment variables that can potentially be modified. For the fellows, avoiding heavy foot syndrome, not looking at the flooring while not looking at the monitor, trying to use Fluorostor instead of Cine as much as possible. Cine is associated with 10 times the higher radiation dose than Fluora is. Reducing magnification, collimating, reducing frame rate, and fluoroscopy dose. These are things that we mostly know. Higher table, for example, subjects a patient to higher dose of radiation. Angulated C-arm angles as well, higher dose of radiation, but conversely for the operator, higher table angle actually may increase scattered radiation, so there has to be a little happy balance between the patient exposure as well as the staff and the operator exposure. Obviously, newer equipment provide good image quality with less radiation to balance things out. I think this image is pretty good, and it kind of balances out what should be in the cath lab, but it's not, unfortunately, in most cath labs, as you have to have a ceiling suspended kind of a shield table lead, as well as you can see it right there in the right lower corner of the patient. There's also a lead apron there, something like a rat pad, or we can just put a lead apron that we do for our patient in our cath lab on the right side to reduce, and that definitely reduces some scattered radiation as well. From a head radiation exposure standpoint, there are lead hats that don't reduce the radiation a whole lot, mainly because, again, you get mostly scattered radiation not from primary source, but from the patient, and a lot of that hits the bottom side of the head. And so there's a very minimal reduction in radiation with these lead hats unless you put a little apron on the side of it, and it can certainly reduce radiation a significant amount. This is studied by Amanis looking at the exposure of the eyes. So certainly there's a threefold increase in the lead lens changes in folks who are working in a cath lab environment, and it is associated with increased risk of cataracts. Lead glasses in figure A, that's the most popular type. It doesn't reduce a whole lot, only 27%, again, because the radiation comes from the bottom and the side. So if you have a lead glass that kind of goes to the side, that's probably better, reduces radiation significantly. Cataract is a big problem. I've had a colleague who's my age and interventional cardiologist. She already had cataracts in her age of 40, which modified her work, the way she works in the cath lab. Real-time dose monitoring can be extremely helpful, can modify your behavior. So you can, if you notice that you're getting a lot of radiation, you can change things that you do in the cath lab and perhaps reduce the radiation exposure for yourself and everyone else around you. This is you don't want to walk into a cath lab looking like that. I mean, you can really protect everything. This is one of the wonderful cath lab techs I had the pleasure to work with. And she used to wear all this stuff and eventually started kind of peeling some of this off because all this lead can eventually wear on you, end up having orthopedic issues. Before I get to the orthopedic issues, I think it's important for us to also talk about interventional echocardiographers now that we're doing more and more structural cases. Interventional echocardiographers get a tremendous amount of exposure to radiation since they sit at the top of the bed with little to no protection. And so there are some newer equipment to help provide some sort of protection for them, although they're kind of bulky. And my imaging echocardiographer, they don't like it so much, but you need to have some solution for them as well. I think there's been previous talks kind of mentioned this 2023 SKY survey regarding orthopedic injuries by cath lab personnel. There's quite a bit about 79% reported musculoskeletal injuries due to wearing lead or working the cath lab. A lot of lumbocervical pain as well. And even it's kind of amazes me if you look at the age distribution here, even in folks who are 30 to 40, 47% of them reported experiencing orthopedic injuries. And I think for a lot of interventional cardiology fellows who come out of a training, they feel invincible and they don't pay attention to these things, and it eventually catches up on them, and you see much higher percentages later on as you get older. 2 to 7 times full higher risk of orthopedic injury in individuals who work with radiation compared to any other medical occupation. So some of the newer things that have been helpful, newer aprons, 20 to 40% lighter, proper fit is very important. Of course, having 2-piece compared to 1-piece can reduce some of that pressure on the lumbar and cervical spine. Upright posture, having shoe insoles, floor mats, these are things that I work on, but ultimately what it is really the lead that kind of does most of the damage on the spine and on the musculoskeletal structure. So some of the solutions in the past is zero gravity. I don't know if anyone that uses this, it only provides protection for the primary operator. It's cumbersome a little bit, and of course leaves the rest of the cath lab staff somewhat unprotected. There are newer stuff out there, Protego radiation shield, and the need for apron for not just the operator, but also the scrub technologists and the circulating nurses as well. Reduces radiation, scatter radiation quite a bit. And again, more importantly, obvious need for the apron. And there are other things like Rampart that provides similar solution as well. It can be very helpful. You can see the primary operator here not wearing any lead. Everyone's talked about exercise outside the cath lab. Super important for well-being, and also important for the musculoskeletal and reducing orthopedic injury. SKY survey also asks the operators if they do any exercises, and about 48% reported doing some sort of cardio exercise, strength training, stretching, yoga. We did a survey ourselves a few years ago, and core workout was only about 50% of the respondents who did exercise did some sort of core workout exercise, which I think is super important. I'm going to skip the slide. There are certain exercises that I think can be helpful. I mean, we have limited amount of time that we can do some core strength exercises. The main thing to avoid, at least reduce the risk of posterior, of cervical and lumbar injury is posterior chain strength exercises. We work with the physical therapists to come up with set of exercises that are quick to do, hopefully, to fit in your busy schedule. On the left side, things that you can do at home. On the right side, 5-minute post-procedure exercises, particularly if you have a long case, took 3-4 exercises, potentially can reduce some of that pressure on the lumbar cervical spine. But I think these newer things, newer leadless kind of devices can be very helpful. So long-term exposure to radiation should be minimized and can be mitigated with appropriate behavioral modifications, as well as setting up appropriate shielding in the cath lab. But ultimately, I think one of the things that we deal with the most is the orthopedic injuries. Orthopedic injuries that primarily are driven by wearing heavy equipment, shielding equipment, lead equipment. And the best way to avoid that, one, is exercises. 2 is if you can get these newer technologies that potentially you don't have to wear lead to avoid all that stress and strain on your spine. The problem, at least for my institution, has been, and a lot of other institutions, the folks I've talked to, has been really the upfront costs and convincing health administrators that it is important to invest in the health of the operators, of the cath lab staff, and that is sometimes hard to convince folks to do, and administration to do, to make that investment. One thing I would say, now I'm 10 years out in practice, you come out of fellowship, you feel invincible, you don't think these things are gonna be an issue for you, but I've had friends and colleagues who are interventional cardiologists who've had injuries. I've had folks who have quit interventional cardiology because of injuries from radiation orthopedic. I've had people who take medication to help with their back pains. Just this year, I started getting injections because of this issue, so I think it's super important. If you want to have a long career and do what you love, I think these are things that you have to take seriously. Thank you.
Thank you so much. That was great. I think that there's, stay here in case there's some questions for you. So Dan, what sort of procedures do you have in your lab, and what do you think is the most effective on a, sort of on a, not a population level, but on a institutional level?
I say the short answer is not enough. The longer answer is we pay a lot of attention to radiation safety. We don't yet have we're not yet leadless, and I think that we really have an obligation to try to get there. But we do pay a lot of attention to teaching fellow staff, nurses, how to minimize radiation and try to take advantage of some of that. But it's clearly an ongoing need for improvement.
Yeah, I appreciate your comments about physical exercise. I feel like that's something I came about on my own. I don't think I have ever heard that at a cardiology meeting until maybe the last 3 or 4 months, and I've seen it in publications and I've seen it mentioned. And I think that's so incredibly important for us, not only as leaders to be incorporating into our lives, but also teaching and modeling that for our staff. And the other comment I'll make is I'm also encouraged, based from the SCI annual sessions this last year, about the leadership that SCI is now stepping up to really push this issue of leadless. I think it's safe to say it's time. I mean, we actually have enough industry equipment available out there that makes this. We need to begin to take the message that this is expected standard of care. And I understand I'm the same way. I'm kind of rearing up for a battle here with my institution, but I think as a society, the message needs to be, this is now standard of care. This is now ALARA to have, leadless systems.
Yeah, I'm horrifically conflicted in this discussion, just so everybody's aware. But if you actually read the NRC codes about ALARA, if there is a technology that lowers your exposure and it's not being used, your institution's in violation of the federal regulations. So if I can't do this because I'm conflicted, but if I were you, I would get that reg, I'd put it in front of the administrator and say, just so you know, if you refuse to buy this, and anybody that moment they're on gets cancer or a back injury, they put themselves at risk. I think if you're choosing to wear lead in a cath lab at this point in your life, go meet Dean Charitakis, who's lucky he's still walking. I'm just going to tell you, I know it takes longer. I know it's cumbersome. We talked about AI being a change. Using leadless systems is a change, but when I retire, I want to be able to play golf and fly fish and hike.
That's a great point. Katherine, actually, you gave it to the right person. We have just a little bit more time. I'd love you to tell us, congratulations, and tell us what you've done to help yourself and protect things while maintaining an incredibly busy practice during your pregnancy.
Yes, if it's not obvious from where you're sitting, I'm like 8.5 months pregnant. So, why are you here? Do Not Fly is next week.
Oh,
so
next week?
Yeah, so I cleared by 1 week.
You're making me nervous.
Yeah. I think radiation monitoring was really important, right? So, have a plan in place. I think a lot of pregnant women say, okay, we're going to get a fetal badge. That's good. I don't think that's good enough. I need my readings back, right? I have no interest in finding out a year later that I was in violation. So, I took a little bit of effort, but, I know my guy is Chris at Landauer. He's the guy I email every month to get my readings back. So, I was not proactively getting my information back on my badges. They had to come to me. I had to go to them to say, give me my readings every month, and I email them every month. And so I kind of know in real time, do I need to adjust my life? I had a plan for what my lead situation would be. So I have a small, first and second trimesters, I had a little small extra apron. I'm now in the maternity lead, which is truly awful. It's very, very heavy. But I would say that goes to, I'm in a lead full lab at this point in time. And so I'm 5'3". which means that my radiation exposure is going to be a lot higher because I'm right there with the patient. So my line is, please lower the screens, lower, yes, lower, shockingly lower. And so, I'm cathing with the screens 18 inches lower than my colleagues so that I'm not looking up at the screens and making sure that I'm ergonomically aligned.
That's just great. Thank you so much for that information. In the old days when I was pregnant, I wore 2 lids. So things have changed a lot since then. Okay, so our next and last talk will be on financial well-being by Dr. Bahadir Simsek. Sorry if I butchered your name. I'm taking after Bill.
Hello, everybody. I'll be talking about the financial well-being for the cardiologists. So my disclosure is that I'm not a financial expert. So let's start with why you should care about this topic. Everybody talked about how people are burned out, how the institutions don't care about them. I'll give you some data about why you should care and how we can help improve our own financial well-being. From the literature, you can find out that about 50% of physicians report being burned out. And in one of our recent surveys, about 69% of interventional cardiologists, they said that they're impacted by burnout to a degree. And when asked what are the leading contributors to their burnout, they said, I'm not making enough money. Believe it or not, it's reality. And White Coat Investor put this tweet out a while ago asking practicing physicians and dentists, if you had $20 million in the bank right now, what would you do? Would you retire completely soon? Would you cut back at work? Or would you keep working full-time? And guess what? If you had $20 million in the bank, they said, the cardiologists or the other physicians or the dentists, they said, I would retire completely or I would cut back at work. That's more than 80% of the participants. So this is from one of our recent studies. Pretty clear, pretty straightforward. This gives you the data. If your net worth is higher, your life satisfaction is better, and you're less burned out. And if you're working more, you feel more burned out. So what can we do about this? How can we do better? So first, relax. Congratulations. If you made it through training, if you've done residency, fellowship, and now you're in attending, you can take a deep breath in. If you're still in training like me, then you have more time to do what I'm going to explain to you. So you're not going to starve, you're going to have a good living, but follow the next steps. So this is from our recent survey. This is from annual full-time income for US cardiologists. The median income was about $600,000 to $700,000. And over here, you see the income and the age distribution. It increases with increasing experience. And on the right side of the screen, you have the median net worth reaching as high as $15 million when cardiologists hit their 60s. So what can we do about going forward? How do we make these things a little bit better? You got to have a long-term financial plan. And the earlier you start, the better it is. You need to spend some time to study finances, okay? White Coat Investor is a good website for this. If you have some free time, go to the website. I'm sure they have some answers to your questions. You gotta know what age you wanna retire at and how much net worth you wanna have so that you can comfortably retire. This is a good start. You gotta start investing early. Compound interest, exponential growth, okay? Human mind has a hard time understanding this concept. Albert Einstein reportedly once said, I don't know if he actually said this, but he probably would have, the most powerful force in the universe is compound interest. I have a simulation over here for you. Let's say you're 35 years old right now, and you have no money invested under your name, okay? And you're now a cardiologist or you're an interventional cardiologist. And you decide that you will invest $5,000 a month, okay? And the index funds that we have in the United States generally give you about 10% on average. So if you start doing this right now, in about 30 years from now, with 10% annual compound interest, you end up with $11.3 million, okay? And of this money, only about 16% is your own direct contributions. 84% comes from the compound interest. So what this tells you is that you gotta really start early on, and I'll tell you more about that. Number 4, you gotta use the retirement accounts. These are tax advantaged. There is a reason why there are limits to these accounts, because you get to keep more of your own money in your pocket rather than having to pay it as tax. So there's a bunch of letters over there. You see 401k, 403b. You probably heard of some of these things. Figure out which ones of these you're eligible for. It depends on your employer. It depends on how much money you're making. But you're going to be eligible for at least a couple of these accounts and utilize them to the max. If you have an employer that's offering match, take that. As an example, there are some residents or research fellows in this group. You guys are probably eligible for what's called as Roth IRA, okay? But if you're an attending, you're probably making too much to qualify for this. So there are other alternatives for you, like backdoor Roth IRA or mega backdoor Roth IRA. So figure out which of those you're eligible for and utilize them. It's pretty much free money. You're not paying it as a tax, and you're keeping it in your own pocket, and your money is going to compound much faster. Number 5, obtain disability insurance. You heard from the presenters, orthopedic injuries are pretty common in interventional cardiology, and radiation exposure is also pretty significant. One of the biggest risks cardiologists face is not being able to convert their experience and their skills that they gained over at least a decade into financial wealth. Given that such occupational hazards, they have pretty high incidence, consider obtaining a disability insurance. In one of our recent surveys, 40% of US cardiologists, they reported that they don't have individual specialty-specific disability insurance. So consider obtaining such insurance, especially early in career. Number 6, consider paying your financial advisor an hourly fee as opposed to a percentage-based fee, especially after you've accumulated a considerable amount of wealth. Most cardiologists in our recent study, they report that they pay percentage-based fee, 79%. So basically your financial advisor, they have an equity in your own net worth. So think about that. You do PCI, you do a bunch of things, you basically charge per procedure. You don't charge based on the net wealth, right? So think about it. Number 7, you gotta know where your money is invested. In our recent study, about 1/3 of participants, even though this information was available to them, they did not know where their money was invested, and they were also unaware of the commissions or expense ratios that they were paying. So take some time after CVI, look up the cost of investing. So wherever your money is invested, you should have access to this, for most people at least. Figure it out. You see these things over here. It says expense ratio. I pulled up a couple funds where it says expense ratio. This is basically the cost of investing into that index fund or ETF or whatever fund you're investing into, and you get charged this every year, whether you make money or whether you don't make any money. Generally, a good expense ratio is less than 0.1%. If you're paying anything more than 0.5% or more than 1%, you probably have some optimization to do. And number 8, consider low-cost index funds or ETFs that minimize your tax liability. In our recent survey, 20% of participants reported that they're buying and selling options in the stock market, and 26% reported that they have half of their net worth in individual companies. And in the same survey, the median participant was working about 60 hours per week. Given that you have such a challenging practice where you're working really long hours, you probably don't have the expertise to read the balance sheets of companies, understand their operating margins and how they're changing going forward, and whether or not these companies are selling at a discount compared with what they're selling at right now in the stock market. So you're probably gambling. This kind of goes to the points that, we're maybe a little arrogant, maybe we like to gamble a little bit, but the burnout rates are pretty high. Everybody feels quite stressed. Should we really do that? So consider minimizing your expense ratios and tax liabilities by reducing frequent trading and by reducing your expense ratios. And for those who may not be familiar with this, when you invest into these, what we call as S&P 500 funds, what you're doing is you're basically buying a percentage of some of the most profitable companies in the whole world, including Microsoft, Nvidia, Apple, Meta. So you get to be an owner of these companies without having to pay almost no commissions. So I think it's pretty amazing. Number 9, minimize debt. It always gives you stress. 15% of participants who graduated from US medical schools in our recent study, they reported that they have medical school debt or they have still college debt. So going forward for maybe next generations, consider more affordable colleges and med schools, and consider utilizing the accounts where you get some tax advantages. Number 10, don't get divorced, okay? There's a saying that says one spouse, one house, okay? So if you're going to get married, consider a marriage that you think that will last. Okay, that's hard, but try. In one of our recent surveys, past divorce had the strongest association with emotional exhaustion. So if you're going to get married, think again. And maybe try to not get divorced, because it can not only destroy your financial well-being, it can also wreck you emotionally. And if you want more information about these, you can look up our recent study that got published. We have more information over there, and you can go through the QR code. And thanks again for the invitation and for the great meeting. I look forward to the rest of it. And if there are any questions, I'm happy to take them.
So just for the record, first of all, before many people mentioned on the studies we did, and they gave credit to me, the person who should get credit is actually Bahadir Simsek, because he's the one who did the work. And all of the things that you've seen, he's actually personally studied himself and actually educated me quite a bit. So thanks, Bahadir.
Thank you for the opportunity, Dr. Velagapudi. I appreciate it.
This was just really great. I don't know if anybody from the audience has any questions, because to me, this is like nitpicky. So you mentioned about this ratio. If this is our pre-programmed fund with our hospital, how could we change that? That's the relationship they have with that organization.
It's a great talk. So number one, most oftentimes you can look up the ratio that you're paying through the website that you have, through your employer, and you're going to see a bunch of different options over there. And most employers are actually, to a degree, actually liable if they're not offering you the low-cost funds these days. So if you're seeing your expense ratio at maybe 0.5%, maybe 1%, talk with them, because they're probably liable.
The other question, did you have a? The other question I had is, can you tell the audience more about the reverse Roth or whatever that thing is called? The backdoor Roth, because we only found out about that recently, but I think it's important to people.
So it doesn't apply to residents really, you're not making that much, but for attendings, so there are, number one, it depends on your employer. There's something called a backdoor Roth IRA, which applies to you if you're making more than about 160 or so a year, where the way it works is you actually put the money into a traditional IRA, and then you take it to you do a conversion and you convert it into Roth, but there are some dangers to it. You don't need to have any money at the beginning for it. For the mega backdoor, you're making a lot more money, and number one, you need to have your employer, number one, provide you with a 401k or 403b, something similar to it, and in addition to that, they need to let you do it. So there are some restrictions to it, so check with your employer to see if this is actually an option. Number three, if those are all working out, after you basically add up whatever you can, which is about $22,000 or so a year, and you get your employer match on top of it, the annual contribution limit is now close to about $70,000 or so. You can put in what you make post-tax into it. There are some restrictions and there are some rules to it, so talk with somebody who actually does it regularly. And then you put your money into it that is post-tax, and then you can actually let it grow in that account post-tax also. So there are some restrictions again, including your income and employer, so talk with your financial advisor on that. But I mean, it's basically free money. You're not making more directly through your W-2 or whatever else income you have, but you're making more because you're not paying the tax or you're not paying the extra interest income that you're getting, so you're keeping more of your money in your own pockets.
The other thing for people out there too is realize that all of the 40 series numbers in the Roth, you can't get at that money till 65 or 67. Exactly. So if you plan to retire prior to that age, you need to be saving outside in a taxable event because you have to be able to get access to it. So you've got to know when you're planning to retire. You've got to know how to manage your funds. Get smart people to help you. You're not as smart as you think in general, but that's another thing to consider as you do this.
Absolutely, absolutely.
Any questions from the audience or any comments
Yes,
from the
please. I
panel?
have a question to ask. So I'm a resident right now. I'm doing all of these stuff, IRAs, specifically this Roth IRA. So question number one, regarding this backdoor Roth IRA, I know for the general Roth IRA, you can always get your basic money out, right? You cannot get the capital gains out. Is this the same case with backdoor Roth IRA?
I believe so. You probably can. If you're maxing out your Roth IRA, first of all, congrats. That's not very easy during residency.
Mm-hmm.
What next you can max out is something you can think of, but you should be able to take your money back out. You're just doing a little difference in terms of how you add the money in. It first goes into a traditional IRA, then you can convert that into a Roth IRA. You just file an extra report when you're doing your taxes at the end of the year. Otherwise, tax implications shouldn't really be that different, but make sure you don't have any money in the traditional IRA that you're contributing your money into. And this is, obviously, you gotta talk with your own advisor. I'm not liable here legally.
Okay. And for an interventional cardiologist, what's the best possible way to get rid of W-2?
From what?
To get rid of this W-2 form, because I know many of the specialties, they are doing their own LLCs, and then they are just themselves, they are presenting themselves for the job. So it's more like an LLC than a W-2 form for them. So what an interventional cardiologist can do about it?
Yeah, great question. So first, if you're employed, most of the time you're not really going to have an option if you're employed by some big university system, etc. But there are some differences. If you're having a private practice, if you're having partnerships, then you got to talk with the people who are actually putting together the payrolls, because there's going to be tax implications to it, whether or not who's paying your Social Security, who's not doing this. So there are some advantages and disadvantages to all of those things, but they're really complicated, and there's really no way I can go over it in 10, 20 seconds. But I don't think there's a really easy way out of it. And that's because the government wants to take your money through taxes. So.
And with that, we will end.
Excellent.
So thank you so much for joining us, and thank you to all our speakers and our panelists.